Thank you. Okay, so I'm going to start with a note. Michigan State University occupies the ancestral, traditional, and contemporary lands of the Anishinaabe, or the Three Fires Confederacy of Ojibwe, Odawa, and Potawatomi peoples. In particular, the university resides on land ceded in the 1819 Treaty of Saginaw. So in providing this land acknowledgement, I offer my recognition, support, and advocacy for the sovereignty of Michigan's 12 federally recognized Native nations, for historic Indigenous communities in Michigan, for Indigenous individuals and communities who live here now, and for those who are forcibly removed from their homelands. I also will work to uphold or to hold Michigan State University more accountable to the needs of American Indian and Indigenous peoples. I'd also like to say thanks to all of you for being here, and a special thanks to Madeline Lenski, who organizes these seminars, and for inviting me to speak today, and a thank you to whoever else was involved in that decision. So I've decided to organize today's seminar as more of an opportunity for myself to introduce, myself to you. So given the pandemic, several of us have yet to meet despite me being here for a little over a year now. So I'm hoping that upon leaving today's talk, you'll have a better sense of who I am, the work I do, and where I see myself going in the future. So I've got about 45 minutes of presentation planned. So please feel free to interrupt me if you have short clarifying questions, but I'd prefer if you have more involved questions that we wait until the end for those. So I'm going to start by telling you more about my people, kind of where I come from. This is also like geographically where I come from, but also ideologically where I come from. And then I'm also going to do some high-level breeze through of three papers, research projects that I've been working on recently. And then I'll end with a discussion of current and future projects. So to give you a sense of where and who I come from, I've got this map here, and I'm providing this information because it informs my research framing and approaches, particularly now that I'm back in Michigan, and that my future research trajectory can be centered here. I also provide this as culturally, this is a very appropriate and protocol way to introduce ourselves. But anyways, I'm an enrolled citizen of the Sault Ste. Marie tribe of Chippewa Indians. My family was enrolled in the 1970s, and our story is not unique for this part of Michigan. There are various census documents showing our family migrating through time from Mackinac Island to Burt area, and then by 1900 or so living in Elk Rapids before moving to the Upper Peninsula, which is where my mother grew up. And I was born and raised in Mount Pleasant, and my immediate family still lives there. I'm also French Canadian, and my father was born and raised in Dearborn. He's the son of German and Irish settlers that moved to Michigan from the US South. And Claire's already mentioned my background to you already, but I wanted to put up this slide so you could see a little bit more about my career path and how I got to where I am. As an Anishinaabeg person, I have the responsibility or obligation to figure out my talents and my role and how I can contribute to my community. And this is one of our cultural values. For me, this is one driving force behind finishing my PhD and for doing the research that I do. And also here pictured, I have my eagle feather that I received upon graduating in 2019, and mostly just showing it because I'm proud of it. So generally, I'm interested in understanding and describing ways that racism, colonialism, and many other forms of isms impact women's health. Most of my past and recent research is about gynecologic and obstetric healthcare access and use, and understanding why several treatments, things like hysterectomy or ovary removal, might differ by race ethnicity. Currently, I describe my work as falling into these three somewhat overlapping bubbles of women's reproductive health, impacts of health policies, and Indigenous health. And you'll notice that those three bubbles are kind of placed within this larger bubble of methods and methodologies. And I put that there because I think thinking about our methods and methodologies within each of those three substantive areas is also a space where I do some work. And I want to draw this distinction between methods and methodologies. In Epi, we focus a lot on methods, these tools of analysis that we use. But I separate this idea of methodologies here to denote or to draw a distinction in the differences between those tools and the ways and we ask particular research questions, or whether we don't ask certain research questions, when and how data are collected and how they're explored, how they're analyzed, and how resulting data are interpreted and used. What are the norms of our discipline, and what power dynamics govern the way we do our own research? And lastly, before I dive into the first paper, I wanted to provide this framework for you. And this is kind of like a big picture on how I think about some of my sort of health services equity work. So in 2002, the Institute of Medicine published their famous Unequal Treatment, which is a report outlining its preferred conceptual and sort of analytic framework for research regarding racial and ethnic differences in healthcare specific outcomes. So when you look at this figure, the non-white group has a higher rate of whatever treatment than the white group. And because these differences are unclear in their cause, we can refer to this sort of mathematical difference between the non-white and the white groups as an inequality. The Institute of Medicine framing tries to assign reasons for racial ethnic inequalities into these sort of just or unjust causal categories. So for example, here, this bottom box includes reasons for the difference that might stem from interpersonal racism on the part of providers, things like implicit bias or incompatible communication styles. And this middle box includes reasons that have to do with systemic level policies and legal realities that influence how our healthcare systems function. Might include things like training, local practice patterns, provider skill, and historical factors. And when you put these together, the Institute of Medicine frameworks deems these sources as sort of unallowable and unjust reasons for there to be a difference between treatment in non-whites and whites. So differences in treatments that result from these factors suggest that the healthcare system is somewhat culpable. The inequality or difference could then be deemed a racial healthcare disparity. And then they've also got this other top box that includes factors deemed as more allowable sources of difference, or rather factors that, if responsible for causing a racial difference in a treatment, would suggest the healthcare system isn't necessarily responsible. In other words, the difference in sort of the rates of the treatment or the procedure is maybe more or less considered allowable. And these factors include things like clinical appropriateness and age and underlying health status and even patient preference. So this framework's useful because it allows for some standardization among studies and attempts to sort of specify normative values around what factors might cause differences in health outcomes that would be considered unjust, not okay, or unallowable. And it has faults, but regardless of those faults, I do come back to this framing a lot as one sort of principled way to guide analyses. So first, I'm going to spend some time going over one piece of my dissertation, which was about building a stronger data foundation to better understand racial differences in treatment with hysterectomy. And I'm starting this section out a little differently than maybe most presentations go, but so rather than kind of bury the lead here, I'm showing you one piece of the results at the beginning to illustrate the issue. So hysterectomy is a procedure which almost famously varies by race ethnicity. Here are the observed one-year hysterectomy incidence rates in North Carolina. And there's, as you can see, a lot of variation by race ethnicity. So for example, the American Indian Alaska Native rate is 77 cases higher than the Asian Pacific Islander rate. That's 10 times higher. And these trends are not unlike those seen in other areas of the United States. I've also here included the race ethnicity specific health insurance coverage for some reference. And so I do this because I want to share that this isn't solely like a story of health insurance coverage or lack thereof. Not saying it's not important, but it's not necessarily the only driving force here. But I also look at this and I think several things. One, that these rates might signal that there's a lot of folks, particularly those identifying as Asian, Pacific Islander, or Hispanic, that might be suffering a lot of discomfort or symptoms related to gynecologic conditions that maybe are untreated or undertreated. And it also makes me wonder about who isn't represented here, meaning like who's getting another treatment when they have a gynecologic concern, who's getting the less invasive treatment that's uterus sparing, who has access to these newer or more state-of-the-art treatments, things like myomectomy or uterine artery embolization. And given that hysterectomy during reproductive years has later life implications, particularly in lowering age of menopause, and that has cascading impacts on cardiovascular disease, it's important to understand who is and isn't treated with hysterectomy and why that might be. So if you're unfamiliar, hysterectomy is the surgical removal of a uterus. It provides treatment for many cancerous and non-cancerous conditions, things like uterine fibroids or chronic pelvic pain, but very few procedures are actually done for treatment of cancer. The overwhelming majority are done for non-cancerous conditions. And because for this work, I focus on those non-cancerous conditions. I do that because I think, unlike in the presence of cancer, treatment with hysterectomy for these non-life-threatening conditions is less clearly indicated and therefore might lead to some latitude in clinical decision-making. Hysterectomy is also common, and in the 1990s, we knew that 1 in 3 women would have their uterus removed during their lifetime. But since then, we've seen overall drops in rates, though it's still the second most commonly performed inpatient procedure among women ages 18 to 65, second only to cesarean section. But today, national level estimates on hysterectomy incidence are pretty hard to make. There are several ways to perform a hysterectomy now, and the minimally invasive versions can be done in outpatient settings. So in fact, the majority of procedures are done that way, which you can see in this figure that I just showed by the upward sloping gray line that represents outpatient procedures, and the corresponding downward sloping orange line are inpatient procedures. Unfortunately, in the US, we don't have national level data to capture hysterectomy done in outpatient settings, and this really limits our ability to provide population representative estimates. So as researchers, we need to be a little more creative in our estimation approaches, and that's mostly what I've done here in this paper. Treatment with hysterectomy also famously varies by several social and political factors. Hysterectomy is patterned by income. So women who are poor or live in states with lower incomes have higher prevalence of hysterectomy. And a similar pattern exists for years of completed school, though that pattern has changed over time. It used to be opposite. Treatment with hysterectomy also varies by geography, so there's more hysterectomy procedures done in the US South. And for a few decades, treatment by hysterectomy has also demonstrated this variation by race. It's well established that Black women have higher rates of hysterectomy than white women, but there's really no contemporary estimates of hysterectomy among Hispanics, Asians, or Native people. And so you might be thinking, like, what's the big deal about removing a uterus? The uterus serves a lot of roles and functions, making its removal associated with both some benefits and harms. But what factors you might think are benefits and harms really depend on several things, including someone's life stage. So for this work, we focus on those of reproductive age because we think many of the harms and benefits of hysterectomy may be most acutely felt or experienced among this age group. So removal of a uterus is associated with relief from gynecologic symptoms, which is likely one reason it's so common. Removing a uterus is also associated with reduced breast and uterine cancer risk and tends to result in decent amounts of post-surgical satisfaction. But some hysterectomy outcomes are more difficult to characterize as like a benefit or harm, like loss of fertility. And uterus removal is sometimes accompanied by experiences of generalized anxiety related to undergoing a medical procedure. There's emotional stress associated with removal of an organ that's so closely tied with femininity. Some report regretting their procedure after many years have passed, or report stigma from medical providers or family members afterwards. And as I mentioned already, uterus removal is also associated with lowered age at menopause, and therefore also associated with increases in cardiovascular events. And so the tensions created by weighing these benefits and harms really contribute to a long history of hysterectomy being questioned as an appropriate procedure. And the site of this work was North Carolina, and this location is significant for a few reasons. It's a southern state, so it has higher rates than a lot of other spots in the US. North Carolina is also racially and ethnically diverse. It's a new destination state, so there's growing numbers of Asian Americans and Hispanics there. Also, North Carolina is home to the largest populations of Native Americans east of the Mississippi, which are shown by different colors on this map. There are 8 tribes in North Carolina and 4 urban Indian organizations. And this is also a good time to talk about the racial ethnic categories that we use through this work. We use these imperfect categories from the federal government's OMB, which include, again, these 5 groups. And we use these categories not as indicators of biological or genetic differences, but rather as indicators of sociopolitical realities and histories that accompany these various racial identities in the US. We use these problematic but common categories to facilitate comparison with previous work. So this first paper's goal was to estimate race and ethnicity specific rates of hysterectomy among women of reproductive age in North Carolina between 2011 and 2014. And we focus on, more specifically, we focus on refining race ethnicity specific hysterectomy rates by addressing 3 of these like methodological shortcomings that are present in a lot of the existing studies. So first, we improve rate numerators by including both inpatient and outpatient hysterectomy. We improve denominators to account for those not at risk of hysterectomy. And third, we estimate rates for a broader array of subgroups than is typically the case in the US-based literature. So I want to do just a quick brief overview on how rates are estimated, and this is important to remember for the next few slides. So rates are created by taking events, in this case hysterectomies, shown by these little people who don't have a uterus anymore, and divided by person time at risk for an event. This is the denominator. It's shown by these little people with a uterus. We then multiplied these rates by 10,000 to create rates by 10,000 person years to standardize. We liked using rates in this instance because they're used to describe new occurrences in an event. They can be standardized by population size and are usually specific to a time frame. For us, we used 1 year. And I've hit on this already, but published hysterectomy rates are essentially inaccurate due to 3 of these methodological issues that I named, but will provide more information on now. So many estimates use data sources that don't capture the recent migration of hysterectomy procedures from inpatient to outpatient. And because now 70% of hysterectomy occur in outpatient settings, you can understand how restricting to an inpatient setting might obscure or misrepresent reality. The implication here is that estimates that restrict to inpatient samples are underestimates because they're missing all of those outpatient cases, but they're also subsetting to a very specific type of woman, particularly those that need to be seen in a hospital setting for some reason. And further, there are differences by age and race in who is seen in inpatient and outpatient settings. The second methodological issue or motivator for this work is a denominator issue. Even if you use the best numerator data, the rates are still likely inaccurate. And that's because most population level rate estimates use census data as denominators. Even when restricting to women, the census doesn't distinguish between those with and without a uterus. So the implication here is that current race estimates are underestimates because they have inflated denominators. Hysterectomy is common, so this isn't necessarily a small issue. And further, because hysterectomy differs by race ethnicity and existing rates are underestimated by different degrees depending on race ethnicity. And lastly, the vast majority of hysterectomy studies don't include smaller populations or group these populations into a group called other. And the implication here is that we have fairly robust descriptions of Black-white differences, but not adequate descriptions for other populations. So rather than conducting a new study to make these rates, we just combined a bunch of existing data sources to create population-relevant rates with improved accuracy. And so this figure demonstrates the impact specifically that our denominator adjustment or the prevalence correction that we did had on our rate estimates. So for example here, the Black specific prevalence corrected rate was 62 per 10,000 person years, but using the status quo rate estimation approach without age adjustment was 55 per 10,000 person years, shown here in yellow. And then the age adjusted rate was 58 per 10,000 person years. So the status quo approach underestimated by 7 cases or 11%. But if we were to go and calculate race-specific differences with whites as the referent, then the Black-white rate difference would be underestimated by 28%, the American Indian Alaska Native white difference by 20%, and the Asian white difference by 5%. And interestingly, the Hispanic white rate difference overestimated by about 2%. So there are racial and ethnic differences in hysterectomy incidence in among North Carolina residents of reproductive age who have benign conditions. With better accounting of the population at risk, we now understand that in several cases, the racial and ethnic differences are bigger than we previously thought they were. And we don't have a good sense of why there's such profound differences in race by race ethnicity. But some implication here is that accurately estimating inequalities in surgical procedures is like one of these first steps in thinking about equity in medical care. This is particularly true when we're talking about an invasive surgery with long-lasting consequences and wide differences across racial and ethnic groups like hysterectomy has. For my second paper here, it's a paper that's kind of about policy, space, time, and eugenic sterilization in North Carolina. I started this paper as a student in a class at UNC, and I finished it last fall while I was here. And the collaborators include a geographer and a historian. And I include it as a demonstration of like one of the interdisciplinary studies that I've done. And so this project allowed us to sort of center historical processes, to recognize legacies and tools of reproductive control, and open the door to some conversation on how historical policies may relate to contemporary experiences. If you're not familiar, eugenics is the pseudoscience of quote unquote better breeding, and included a lot of programs in the early 20th century, the Better Baby or Fitter Family competitions that would have happened, or also some states implemented marriage limits based on demographic characteristics. And another form of sterilization of eugenics practiced in the US was sterilization. which is the one I will talk about more here. Eugenics policy in the United States didn't really have federal oversight, and that's important to mention because it meant there's a lot of variation in the logistics and how it was implemented, but also interpretation and who a state or a community deemed unfit to reproduce. North Carolina was one of 32 states that participated in some form of eugenic sterilization program. And during the process of their program, they sterilized about 8,000 residents. It started in the 1930s, well, really the late 1920s, and remained on the books until the 1970s. In North Carolina, the targets of the program included the feeble-minded, quote unquote feeble-minded, which included those with epilepsy or those with intellectual disabilities. But the program also targeted those in poverty and eventually Black women. And this is in contrast to a state like California, which really focused in mostly their sterilization efforts on Latinx women. So I think that specifying the targets of this program really provide this articulation of who North Carolina as a state considered desirable and undesirable future citizens. But the state program at North Carolina was organized. There was a 5-member eugenics board. It was based in Raleigh, North Carolina, the capital. And this 5-member board was voluntary, but provided oversight to the program. It included the state's attorney general and other state commissioners or directors of various departments. And the role of that group was to approve or deny petitions for sterilization. But they met monthly, so they were able to kind of provide this opportunity for knowledge transfer and education around eugenics, talk about legal procedures, and again, talk about sort of the supposed effectiveness of sterilization as advancing eugenic goals. The program also eventually had one or two paid staff members, and they promoted, monitored, and reported the program's progress. They educated people on it, created educational materials, and traveled throughout the state to get support from governmental representatives and also community leaders, including physicians, nurses, and librarians. And also importantly for this work is to mention that the state had 2 processes or programs that they used for their sterilization. So the first, they had a program for those who were institutionalized, and that basically meant people who were in mental hospitals or youth correctional facilities or schools for the deaf and blind. Their petitions from the superintendents of the institution would be made to the board, and then the decision would be made. And then there was also this program among those that were non-institutionalized. And this one's different in that petitions were usually initiated by social workers or public health workers in counties, and then taken to the county superintendent of public welfare, who then would take their requests to the eugenics board. So we know that those with mental health concerns, those with intellectual disabilities or epilepsy, and those in poverty and eventually being a Black woman were associated with being sterilized in North Carolina's program. But we were interested to know if there may have been a spatial component to the association. So we decided to analyze how sterilizations performed as part of North Carolina's eugenic program evolved over space and across space and over time. We hypothesized, though, that for logistical reasons in the earliest years, counties that were closer to Raleigh would have higher rates of sterilization than those located farther away. And then as time would pass, that distance to Raleigh would become less relevant in later years, as the message of the board was heard by more audiences, local proponents and funding shifted, and the demographic targets of the program changed. We also hypothesized that distance to Raleigh would be associated with county level rates among non-institutionalized individuals, but not for those who were institutionalized. And I can talk more about why we felt that way if you want to know. But throughout, I'll show results for both institutionalized and non-institutionalized settings. Our thinking is that the institutionalized specific results serve as sort of almost like a negative control. It's not a negative control, but you can kind of think of it that way. And so while this figure is part of our results, I'm using it to provide a little more context or background about the program in North Carolina. Not unlike other states, they kept their eugenics program running for many decades, which allowed opportunities for the policy's focus to shift with time. So it took the program a few years to get off the ground. But the earlier years of North Carolina's eugenics program focused efforts on sterilizing institutional individuals in about a dozen state institutions. Later years saw an expansion of sterilization within the non-institutionalized population, so that by the 1950s, state officials began promoting the procedure as a way to address these interconnected social problems of poverty, feeble-mindedness, and delinquency, as well as growing welfare-related costs. So the logic was that by sterilizing poor women, the state could offset future costs associated with supporting families via welfare. And also, while these data that I'm showing you here aren't disaggregated by sex or race, we do know that fewer males were sterilized in the later years, and despite the lower cost associated with their sterilizations. Also, the racial targets of the program changed over time, with Black women being more commonly sterilized than whites in the end. But by the time the 1960s came around, the program had mostly fallen out of favor. At this time, also contraceptives were becoming available, or were available. But the changing trends of the program underscores the idea that North Carolina's eugenics policy implementation was influenced by prevailing social norms and processes like gendered, classed, and racialized views and values regarding reproductive capacity. We also used exploratory spatial analysis tools like the Global Moran's Index and the local indicator of spatial correlation called the Local Moran's Index to look at the spatial distribution of female sterilizations and if it changed over time. So the figures on the left show county level sterilization rates. The darker the color, the larger the rate. And I've included the Global Moran's Eye statistic and its interpretation below each map. But essentially, in the earliest year shown here, the rates for those in non-institutionalized setting demonstrate some spatial clustering rather than having a random spatial pattern, suggesting there's a spatially relevant pattern to the sterilizations, particularly in 1947. This clustered pattern disappears as time goes on. The figures on the right show results from the Local Moran's Eye analysis, which basically decomposes this global statistic into county-specific statistics that give an indication of the exact locations where the counties are located that have similar rates, similarly high rates or similarly low rates. So if we focus in on these 1947 maps, you can see that for the non-institutionalized population, there's a cluster of red counties in the middle of the state. And this is a group of counties with high rates of sterilization. And for reference, this is the area right near Raleigh. And for the institutionalized population, there is not a similar clustering in that same location. And again, if we look just at the institutionalized, non-institutionalized maps, we notice that there's a cluster of high rate counties, those red ones. Those red ones start to shift eastward and then eventually disappear over time. And this is one more way to kind of look at these data and to address our last aim, where we calculated distance decay curves in sterilization rates. So distance in miles from each county centroid to Raleigh are along the y-axis and the sterilization rates along the x-axis. And we use these figures to explore this relationship between county level sterilization rates and proximity to the location of the eugenic board and where they held their meetings. So the bottom row includes those in non-institutionalized settings. And for visualization purposes, we stratify by decade. So let's focus here on the non-institutionalized, or the bottom row, in 1947. The red line here, if you pay attention, we see that the highest rates are seen in counties closest to Raleigh and then become nearly non-existent around 100 miles outside of Raleigh. In the 1950s, though, this association between distance and Raleigh remains, that we start to see that the highest rate counties are those about 50 miles outside of Raleigh. For those in the institutionalized settings, the story is a little less clear, but doesn't seem to match the trends that we see for the non-institutionalized population. And I do have extra slides on sort of some descriptions that we have about doing, we did some historical analyses of documents and things to kind of explain and inform our hypotheses, which I'm happy to talk to you if you're interested in knowing more. But essentially, in the 1940s, sterilization rates were highest in counties closest to Raleigh, and in later decades, clusters of high-rate counties were located further away. The spatial clustering of rates in early years suggests spatial factors mattered more earlier than it did in later years, and the structure and evolving ideology of the eugenics program allowed for local level factors to become salient in implementation of eugenic ideology. We know that an individual's race, socioeconomic status, and intellectual capacity are determinants of sterilization risk, but geography may have also been a determinant, particularly in the program's early years. And so while eugenic sterilization isn't practiced in the US anymore, a more thorough understanding of this historical context is important, I think, for thoughtful investigation into factors that shape contemporary reproductive health policies, health services utilization, and larger societal views of fertility and reproductive capacity. And for the last paper that I want to review, it's around inequalities in Cesarean birth. And this paper is a paper that's in progress. So I look forward to your feedback on it. So cesarean section is the most common surgical procedure among reproductive age women in the US. Population level estimates suggest cesarean birth, particularly a low risk primary cesarean, has decreased in recent years, though these estimates definitely obscure persistent racial and ethnic inequities, which may be increasing over time. While life-saving in certain circumstances, cesarean birth also poses risks for mothers and infants. Primary cesarean birth incidence, at least in the last 6 years, has been highest among Black individuals and lowest among American Indian and Alaska Native individuals. But given the higher prevalence of many of these risk factors among American, or the risk factors for cesarean among American Indian and Alaska Native individuals, things like hypertension, diabetes, obesity, macrosomia, the lower incidence of cesarean birth in this population is a little unexpected. And given racial disparities in maternal and infant morbidity and mortality, increased attention to obstetric procedures, especially those exhibiting racial differences, is warranted. Beyond individual level risk factors, cesarean birth is also influenced by structural and healthcare system specific factors, things like geography, practice patterns, payer type, provider availability, and hospital type. Yet few studies explore the potential impact these factors have on racial and ethnic variation in cesarean birth. Further, few studies look beyond low risk cesarean birth to explore racial differences. So our overall goal here was to estimate population level American Indian, Alaska Native, and white differences in cesarean birth incidence. We had two aims, and the first was to describe basically maternal, clinical, and obstetric characteristics, cesarean birth indications, and cesarean birth incidence, both within and between the American Indian and Alaska Native and white US obstetric population. But I'm focusing this presentation here on our second aim. And because the equity of healthcare systems should be evaluated by comparing clinically comparable patients or patients with similar clinical need, or at least as specified by the Institute of Medicine, we accounted for differences in clinical and obstetric risk factors as well as indications for delivery to explore population level American Indian and Alaska Native white differences in cesarean birth. So for this project, we used Natality Files or birth certificates from 2017. And we wanted to account for factors that would be considered, those quote unquote allowable reasons for cesarean delivery to differ by race ethnicity. These are clinical characteristics, obstetric characteristics, and procedure indication. And the clinical characteristics included maternal age, pre-existing hypertension, pre-existing diabetes, and obesity. And the second set of factors to consider were obstetric risk factors and included hypertensive disorders of pregnancy like gestational hypertension or eclampsia, gestational diabetes, or fetal macrosomia. But for the third set of factors, indication for delivery or for cesarean, we used the Robson classification system, which delineates the varying circumstances during a birth by which cesarean delivery might occur. So this is a systematic classification that's used by the World Health Organization and was created and intended to be used to help medical facilities determine the types and scenarios where a cesarean birth might be over or underused. It includes a set of 10 mutually exclusive and replicable definitions for delivery indication that separate term and preterm birth, nulliparous and multiparous women, multifetal and singleton gestations, and vertex cephalic versus other fetal presentations, as well as accounting for the type of labor onset and if previous cesarean had been performed. So for this analysis, we took two Robson groups 2 and 4, and further subdivided them into separate instances of pre-labor cesarean births, and which increased the number of total groups to 12. And then also we added a 13 group, which is a group of folks that didn't fall into one of these 12 predefined categories. This is a really small group. And to account for these allowable sources of difference between whites and American Indians in cesarean delivery, we used a method that standardized the American Indian Alaska Native group to make them more similar to the white group with respect to the three factors I've already mentioned: clinical and obstetric risk factors and delivery indications. So this resulted in a counterfactual incidence, which could take several values, and each of those values I've represented here in light green. Regardless, though, the counterfactual incidence that we calculated is being compared against the non-weighted incidence of the white group, or the observed incidence of the white group. The resulting estimated difference in cesarean incidence can then be interpreted as the inequality in cesarean incidence between American Indian, Alaska Natives, and whites due to factors other than their underlying health status or clinical need. And so here's the steps that I took to, or that we took to estimate the counterfactual incidence. And so first, I'm only comparing two groups, right? The white group, which is the referent, represented with a solid line, and the American Indian Alaska Native group, which is represented with the dashed line. Second, I calculated propensity probabilities that represent the propensity of whiteness based on age, indication, clinical, and obstetric risk factors. But I want to take a second to acknowledge how awkward it is to say standardizing to whiteness. I just mean to say that I'm standardizing to the distribution of clinical attributes and obstetric attributes of the non-Hispanic white group of women. Third, I used these propensity probabilities to calculate a weight for each person. So all white patients got a weight of 1, while each American Indian Alaska Native individual got a weight equal to the odds of quote unquote whiteness, conditional on the standardization factors I've already named. And then fourth, the weights were then used to standardize this American Indian Alaska Native group to the white group to make the two groups similar with regard to those 3 sets of factors I've already named. And then lastly, the reweighted counts were then used to calculate this counterfactual cesarean birth incidence among American Indian Alaska Natives. So application of these weights resulted in a population of American Indian Alaska Native individuals that were equal in size to the white population that had the same distribution of indication, clinical, and obstetric risk factors. This allows for a comparison of the incidence of cesarean births after accounting for sort of quote unquote these allowable areas or allowable factors. So the cesarean incidence estimates among the white referent group are marked with the black box, and the estimates among American Indian Alaska Native births are marked. The observed one is marked with a dark blue circle, and the one after weighting is marked with a red asterisk. So when weights are applied, the cesarean birth incidence increases for American Indian Alaska Natives from 28% to 33%. So while the American Indian Alaska Native had lower cesarean births prior to weighting, once we equalize these obstetric, clinical, and indication related factors, it turns out that they experience cesarean birth more frequently than white individuals. We did a second propensity score analysis using the same approach I just outlined, but after stratifying by Robson classification groups. So remember those like 13 groups that I mentioned a few slides ago. And this approach allowed us to determine the extent to which clinical and obstetric risk factors can also contribute to these Native and white differences in cesarean births, but within each Robson group. One criticism of the Robson group is that it doesn't consider clinical or obstetric risk factors. So from this, we learn that among the low risk group, Robson group 1, this is like the primary cesarean section group, that American Indian Alaska Natives have a higher incidence of cesarean birth. And we also learned here that among Robson group 9, those with fetuses in transverse or oblique lie, that American Indian and Alaska Natives also have a higher incidence of cesarean birth. So upon equalizing health status, if we were to assume healthcare systems function similarly for the two groups and that race doesn't really matter in clinical decision-making, we'd expect the cesarean incidence to be similar between the counterfactual American Indian Alaska Native population and the factual white population. But that's not the case. When whites are the referent, the weighted incidence of cesarean births among American Indian Alaska Natives increases and surpasses that white cesarean incidence. This is particularly true for group 1, which is often considered the low risk or elective type of cesarean birth, and group 9, which might indicate lack of access to external cephalic version or grand multiparity or something or both for the American Indian Alaska Native group. In any case, the implication of all of this is that health status may be responsible for some, but not all of the difference in cesarean incidence that we see. So race could play an important role in clinical decision-making. There may be structural or institutional differences in the healthcare systems between where American Indian and Alaska Native and whites tend to give birth, or there could be another set of unidentified factors that might be important correlates. And so now I'll just move into the last section, which is kind of like this hodgepodge of sorts that describes some of the work I'm currently doing or working towards. But first, I want to describe sort of a vision that I try to embody with my epidemiologic work, and this sort of describes what I aspire to be doing. So in this paper that's cited at the bottom of the slide, Erica Pressing, she's an anthropologist, she interviews Indigenous epidemiologists from around the world, and to understand how they think about their work. And she says in reference to those she interviewed that they're strategically levering the more well-recognized credibility of quantitative evidence in general and of epidemiologic methodologies in particular in order to procure the recognition and resources needed to protect and promote health. This is an epidemiology for and by Indigenous peoples. I've also included some common but not recognized roles of epidemiology that I strive to exemplify. That's of an amplifier, using my voice to highlight other voices and issues that don't get much attention by society. As translator, to move beyond sort of the epi-ease to make research and concepts approachable for those without an epi background. A synthesizer, to take disparate information or data and wrap it into a single digestible narrative or a story. A bridge builder, to combine disciplinary approaches with epidemiology to produce results that resonate beyond epidemiologists. And accountability, determining who should be held accountable, why they should be held accountable, and what ways they can be held accountable. And again, this slide, it sort of provides a conceptualization of an epidemiology that I want to guide my work. So Claire mentioned this. I'm currently working on a pilot project called Indigenous Approaches to Postpartum Mental Health, exploring opportunities for community-based solutions. This was after receiving funding from MSU's Science and Society at State seed grant. And this is in collaboration with Heather Howard-Bobowash, who's an anthropology faculty member here. And basically this funds a graduate assistant and compensation for consultants. We've are basically now just signing and starting our preliminary conversations and consultations with our partner organization, who's the Intertribal Council of Michigan. And some of the guiding questions we're using for our interviews are, how are Anishinaabe women doing in terms of mental health after giving birth? Do they have particular mental health concerns? What supports, including cultural, do they have? What do they need? And how can services be created or improved to help them? This is a relationship that I've been building with the Intertribal Council of Michigan, one of several projects I work on with them. But they've identified this as an area in which they have noticed that there's some work that could be done given higher rates of postpartum mental health concerns among Michigan's Indigenous populations, or at least the people they've been working with. And in terms of future research, to build off what I've already done and the pilot work I'm currently doing, I'm trying to sort of hit this sweet spot of the intersection between all these three research bubbles that I've mentioned. And so as Claire mentioned, I've recently put in a postdoctoral career transition award, a K99R00, about perinatal mental health and pathways to care among American Indian women. And also Robert Wood Johnson Foundation projects with Claire and Colleen also on the impacts of the Affordable Care Act on equity in healthcare access and utilization for Indigenous women. This one is, the second one is more about exploring heterogeneity across the United States in Indigenous women's healthcare use, particularly surrounding changes that resulted from the Affordable Care Act. The Affordable Care Act included a lot of Native specific provisions, yet there has not been really any systematic look into how those have played out for different Native nations. And also we're trying to understand, or would like to understand better, how individual sovereign nations interact with federal policy and how that can, create a lot of heterogeneity in response to federal policy. And as Claire mentioned, this past fall, I taught Epi 380. And this is the second course offering in a two-part course that's required for the minor in global public health and epi. And the focus is on biostats and analytic methods that you commonly find in public health. I inherited a lot of the material for this class, but I tried to approach this course in a way that was inclusive and also try to use the following question as a touchstone or guide, like, does this curriculum allow students to advance health equity? I enjoyed teaching this quite a bit, and I learned a lot. And more importantly, I think students seem to get something from the course, even though I loaded them down with a lot of work, as is said by a student here. But I really look forward to and welcome future teaching experiences. And then I want to end on something that's a little more fun and maybe a little bit different than what we've seen in standard epi presentations. But, I went through a PhD program in social epidemiology, and oftentimes social epi is considered sort of the social justice oriented epidemiology. But I also realized in my experience that I had never heard some words like decolonization or resilience or resurgence historical trauma, things like that, and several other similar concepts that I think are key to community and other organizing on the concept of social justice. So I wasn't alone in thinking this, and several of us got together while at UNC and created a zine. And for those of you who are not familiar with the zine, it's like they started many, many decades ago, but it's like a self-produced booklet that's meant to like sort of educate folks on or raise awareness around certain issues. So we solicited submissions from students and faculty in our department, and after getting 28 entries, we organized and categorized them and titled the zine, "Weight is in All Epidemiology, Social Justice," and that's what's pictured here. But as stated in our zine, we say no, or perhaps not yet, but we'd like to work towards integrating these two arenas in our public health research and practice. And so we, make that zine available to students, particularly new students coming into the department, and continue organizing around these concepts there. I'm not that involved in that anymore, but also in addition to, I think zines, using them as like a tool for reflection, I think they can also be used as in an alternative way to disseminate research findings or as student assessment. And so I had a few students choose to make a zine rather than write a standard manuscript or give a PowerPoint presentation for their final project in the class that I taught last semester. So I'd like to take a second to acknowledge Madeline Lenski, again, for asking me to present and coordinating these seminars, Dr. Clara Margerson and her lab for the support and the reviewing of my slides and giving me a chance to sort of practice this presentation earlier this week. Also my collaborators and mentors who I've mentioned, and the funding sources I've received. So miigwech, thank you. And I will go ahead and take these slides down and maybe we can have some conversation.
Thank you, Dr. Gartner. That was great. And any questions or comments are welcome now.
Good job.
Sir, do you want us to raise our hands?
Go ahead, whoever started.
Yeah, just go ahead.
Hi, Danielle. This is Zhihui.
Hi.
Hi. I'm very impressed. I have a very common, I get a kind of question, maybe for your second study. That idea of doing this weighting is really, really interesting. I think it's very similar to the regular propensity score, like weighting approach, but which has this problem that after weight, we know that along each dimension that you looked at, the distribution is the same, but jointly we don't really know, right? Have you seen any improvement on that front, or like a multidimensional thing?
No, I haven't. I think that using this method in like this health disparities context is so like it's newer. I don't see doing it.
Yeah.
Yeah, and so there's a couple papers that came out like in the from Ben LeCook, who's at Harvard, that have talked about this approach and its usefulness in terms of trying to like standardize a way that we talk about disparities in healthcare. So yeah, to your question, I haven't seen any work done in that space, particularly in this context. Yeah.
Well, the overall results is very, very different, it seems like, right? But when you stratify it to the 10 groups, it seems like only 1 or 2 have difference. So why the overall result is so significant?
Yeah, great question. I'm trying to unpack that right now. And so I've looked at, applying just like the weights for the clinical factors, weights for the obstetric factors, and try to get a feel for it. And I think what's actually like really one of the main drivers that's happening for this overall difference that I noted or showed is the age distribution by which people are giving birth. So natives tend in the US to give birth at earlier ages, or at least start giving birth at that age. So in 2017, there were a lot of like younger Native women who gave birth. So, and fewer older ones. So I think what happens in the process of weighting is that we have to like, you know, really significantly upweight the older people of the native population to match that of the white population, in which a lot of older people give birth, right? So I think what's happening there is like there's some pretty heavy weighting of those like older natives, which are a unique group of women, I think, and kind of outside the norm.
Right. You probably report this in your paper, but it would be good to know the actual numbers in each of those strata.
Mm-hmm. Absolutely.
Right? So maybe only like the first stratum has lots of people, but not on the other groups.
Yeah.
Okay.
Yeah.
Thank you. Thank you very much.
Danielle, this is Dawn. I have a question about what your thoughts were on restricting your studies to just Native American women instead of concerning yourself about propensity scores and different approaches to weighting. I just gave a lecture to the students a couple days ago about the fact that I thought counterfactuals might not even really work in some instances, arguments against them. So just kind of wondered what your thinking was about that.
Yeah, I mean, so I think there's maybe two questions you have there. One is, I did actually do this work also thinking about the Black population and reweighting them to the distribution of white folks, because we know a lot more about like the about risk factors for cesarean birth, particularly among Black women. And but part of the thing is that like, right, like a lot of these clinical and obstetric risk factors are actually shared by these two groups, right? Black women and Native women. So I thought that like comparison of all of them kind of works, but I think in one paper it's like too much to kind of present. So that was the like idea behind just focusing in on the Native population. Plus, like there's just so little published on this population. So that was like one piece of the thinking. And in terms of like thinking about the counterfactual, like this is one reason I like this approach, is because the counterfactual is a lot clearer to me on what it is, versus like doing something like, you know, like a multivariable model where you have like your race coefficient and then you have the other like set of covariates in there. You know, the kind of implied coefficient is, or the implied like counterfactual is like, what if all these Black people are now white? Which is like, what? Right? Like no one knows what that means, right? Like the world in which that happens does not exist. But in the way that this propensity score works out, it's like trying to think about, well, what if we lived in a world in which like we could make sure that people aren't experiencing, you know, or that they at least walk into the door of a hospital with similar like health status and a similar health status. And that to me is like a lot easier of a counterfactual to wrap my head around. It still like feels like a reach, but like in terms of like where we are as a society, but like it got me to a spot where I was like, okay, I can kind of start to imagine what that world would look like, right? That like, what if like, you know, Native women showed up at the hospital to give birth and they clinically and obstetrically and indication wise looked just like all the other white women. And that's what this like disparity was trying to estimate.
Yeah, I guess I still have a problem with that because I don't see how you separate health from like historical trauma and experiences
Absolutely.
in the rest of life. So.
One of the like main criticisms of that, like of this approach, you know, is thinking like somehow that the healthcare system isn't responsible or shouldn't have to take on historical trauma, or, you know, in their treatment. Yeah, I'm 100% with you. I have like a whole commentary I've written about it, but haven't done anything with.
Can we think about that question as being kind of that this method is sort of breaking it into different parts or pathways by which the you know, racial treatment and structural factors and historical trauma operate? So the factors that you're sort of like adjusting for are those that, you know, that, you know, those are ways that all of these structural factors operate outside of the hospital. And then what, you know, you're saying, so if we make everyone look the same when they arrive at the hospital, then we're looking at the way those structural factors operate within the hospital or the clinic or the healthcare system. So it's not to say that it's reasonable to think that people would all show up looking the same, or to ignore the role of structural factors in those like clinical and obstetric risk factors, but to kind of focus in on a different part of the pathway.
I tend to think it's kind of inextricable, but that's kind of where I land on this. But.
Yeah. Jim, I see you now that there's a hand raised.
Hi, it's Jim. Great talk. Congratulations. This is the first talk in almost 50 years in which someone in the Department of Epidemiology has talked about the eugenics movement as evocatively as you have, and I appreciate that. Thank you. I put in a note in the chat, a link to early work in the 19th century about Edward Jarvis, who worked in Massachusetts. And he's interesting for two reasons in epidemiology, one of which has to do with your talk specifically, which is his studies of how the distance of one's residence from public mental hospital influenced the admission rate to the hospital, which resonates with your sterilization and distance story. He also is perhaps infamous for making the mistake that the mental health of the African slaves in the plantation colonies and states of the United States was better. The mental health was better in the slave states than it was in the free states. And so Jarvis had admitted his mistake, but then he continued in that research and published a correction of it within, I think, a year or two after he made that mistake. But it's very early epidemiological work on health services and known to us in psychiatric epidemiology as one of the first mistakes in our field. I also wanted to mention that in Virginia, at Western State Hospital, where many of my relatives were employed, there was a physician named Joseph D. Jarnett, who was an advocate of the eugenics movement, and his work might be of interest to you because it's in proximity to North Carolina, and you might find interesting patterns that have to do with the location of the hospitals where people were being cared for psychiatric problems and the impacts on sterilization. Anyway, it was a great talk. I really appreciate it. Thank you.
Oh, thank you. Yeah, and thanks for those references. I feel like this Jarvis paper sounds familiar. I took like a healthcare geography of healthcare class once, and I want to say we maybe read this as one of my as a paper in that class. But thank you for mentioning it. Yeah, and this idea of like the role that physicians played, you know, in the eugenics, I think that's one of these factors that really like had a spatial, added this spatial component to like how North Carolina's program played out. For one, like you see like parts of Raleigh, like or near Raleigh, this is where like social workers, like there were hubs of just like social work activity and training happening in the 1920s. And into the 1940s. And that's also, you know, so you have this whole group of people that are trained in this ideology. And that's also where you see these like really high rates happening. But you also then have physicians who are like in other counties who are just using this tool. And there's documentation of this, using this tool of sterilization as a way to actually, I think this was rare overall for the state, but was using this tool of sterilization as a way to sort of give women reproductive autonomy for some that already had too many, like what they considered to be too many children and didn't want to have more children, that, you know, participating in this program was one way that they could take more control of their reproductive health. And again, like that was not a common thing, I don't think, around North Carolina, but you do see some physicians taking that on that mantle kind of and helping and using the program in that way.
Yeah. Very interesting. Thank you.
Mm-hmm. And Gustavo, I see that you put something in the chat about a chapter from the book The Gene on the eugenics movement. So thank you. Oh, I can't hear you. You might have your mute on.
No, I think that I was late, and so I got the last part. I mean, that book is I think that chapter is it's not only the US, it's the US and Europe, and
Mhm.
starting from Galton, and very interesting.
Yeah, thank
review
you.
that he does.
I think maybe you were doing this throughout your talk, but I seem to remember you want to distinguish methods and methodologies. And I want to ask you to summarize a little bit on that. And and earlier when Don was asking this question, I think I missed the point. I don't quite understand exactly what's going on there with that debate. Okay, if you could explain, that would help.
Okay, well, maybe I'll start with the methodologies, and then we can move into the other one. Yeah. So I didn't talk about any of this work that I've been doing sort of in the space of methodologies, I guess, but there's also some papers that I've worked on more recently on sort of like how we do public health research, and like the ways in which we sort of focus our approaches and ask the questions that we ask in the way that we do our work. So, and I would actually say some of this falls in the realm of like, I think public health ethics. So for example, I've worked on have a book chapter that'll be coming out soon on sort of like the ethics of approaching working with Native nations around healing historical trauma, and like what does that relationship look like between public health folks who are non-Indigenous and working with Native nations, right? And so like trying to inform like what are some good practices or promising practices that could be used in that space. And also I'm working on a paper too right now about this concept of indigeneity, but also about Natives and how we, we're dual citizens. We are citizens of the US, but we're also, if we're enrolled, citizens of a nation. So that gives us this political identity that makes us kind of different in some ways. And we think that difference should inform some ways that public health research happens, and sort of suggesting ways that we can change our sort of status quo approach to capturing information about who qualifies as being Native and who isn't, and why that changes and matters over time. So I consider that like methodologies work. It's not like particularly like methods, right? It's methodologies. It's about how we think about, identity, and how we think about race, and how we think about the way we do research. And another paper too that I put out recently was on the way we fund schools of public health, and particularly like with this sort of new theme of naming schools of public health after wealthy donors. Right, and like what does that mean for like the way that we teach public health, and how outsiders view these schools of public health and things. So that another one is kind of the way I think about methodologies, right? It's like not exactly the way that we do research, but it informs how we approach research, and could inform people's perspective of our research and things like that. Does that help kind of draw a little distinction? Cool. Okay, great. And then your second question, though, was about, I think the question that Dawn was raising. Yeah. And just because my brain isn't really awesome at this time of day, could you rephrase like why it is that what your question is, and then maybe we can chat through it?
I think maybe Dawn could ask again, because I didn't understand the question, I think. And then
so really what I was asking Danielle, she was showing lots of good methods for when you have a multiracial or multi-ethnic study, and you're trying to understand that there might be, what the risk factors are and what the associations are. There are ways to try to make the groups as similar as possible statistically, to be able to make a conclusion about what was really important. And in much of my work, I moved away from the comparisons to really looking within the population. Mm-hmm. And studying just the group. So for things like racism, you get such extreme confounding if you're trying to look at whites and blacks, like what is the meaning of racism in whites? And does it really have a meaning anyway? And so we pretty much just do a single racial group in our studies. And it doesn't mean I wouldn't have to be concerned about confounders and about other issues that aren't the same within my group. But it's a different perspective on doing it. So it's not that I think you should never do a comparison, but I just wonder what Danielle thought about that. Yes, you can do a lot of this math, but is it really going to fix what the intrinsic problem is?
Yeah, and also to that note too, I didn't mention, but I've So done like probably 4 iterations of this project, that Cesarean one, and each one is quite a bit different, and that's how I guess papers work maybe. But I have done a within group analysis too, and I think that was the idea, was like maybe that's like a second paper to follow up on.
Yeah, because I think the interactions it's hard sometimes to do the interactions, and I do think there are a lot of factors that act differently in one group versus the other, and it's hard to model all of those interactions sometimes when you're dealing with multiple groups.
Yeah, and I especially think given healthcare systems available to Native folks, it's just such a different world, right? Like, yeah.
But then how do we answer the question about disparity or inequality with the one racial group analysis?
Well, the question is, do you need to answer the question of why the difference, or do you need to figure out how to improve outcomes in the one group and what leads to better outcomes within that group? Because within that group, there are some folks within that group that do very well. And so maybe the question's more about why does part of their group do well and what's different about that group that maybe would lend itself to changes for the rest of the group. And that's roughly how I think about it. I don't know if Danielle thinks about it differently.
Yeah. I don't know offhand. I have to think about it.
Do you have time for another methodological question?
Oh, I have time, yeah.
So it has to do with the what I thought was a quite eloquent description of the race ethnic categories that the U.S. Census enforces, and whether your numerators are also characterized by the same OMB census type specifications for those subcategories. And if not, how were you able to address that in your research?
Yeah, so you're talking about the first paper, the hysterectomy paper?
I'm thinking that's the one, but I'm thinking about your one where you say, all right, the numerator are people who have had hysterectomies, and the denominator are people with it and without.
Yeah.
And so if I think about the numerator, it's coming from some database on operations or procedures, and often those databases don't include the OMB or U.S. Census type subcategories.
Yeah. So North Carolina, it's about I think maybe one of 28 states who systematically collect these outpatient specific and inpatient hospital discharge data. So these are billing data essentially that I used, sort of the administrative records. And so North Carolina, interestingly enough, in I think 2011, actually had a statute to mandated reporting of race ethnicity of all patients. And so missingness of that data is very small. Now, of course, what is the quality of that data? Something that probably needs to be explored, because we certainly have stories of people, saying oh, someone at the desk just, the administrator looked at a person and then checked the box that they thought was appropriate. But it is mandated by the state that it should be self-reported. So,
Right.
And they happen to use those categories. They used 6 categories. They had a Hispanic, non-Hispanic category. So we just, made it so it could harmonize with the OMB system.
Gotcha. And then do they allow people to mark more than one category as the U.S. Census now allows?
No, but the maybe upside to that is that I used data from the National Cancer Institute's, the SEER database for my denominators, which comes from a partnership between NCI and the National Center for Health Statistics and the census. So they had already done kind of this bridging work. So even for the denominators, there was no group called other, or multi or anything like that. So it was actually really handy that they harmonized so well.
Terrific. You answered my question. Thanks a lot.
Yeah.
Hi, Danielle. I had a small question. Can you hear me?
Yeah, absolutely.
Oh, perfect. So this is Marzia. I just had a question about the methods, and this is more explain it to me I'm 5, because I really don't understand well the sort of, so I understand that the adjustment for race within a model would kind of obscure certain problems in equitable care outcomes, and propensity scoring in this factual, counterfactual groups would kind of overcome that. But that's a sort of the theoretical underpinning of the approaches that's different. Would you expect the conclusions of if we were to do either approach to be different, or is there something that I'm missing?
No, that's a good question. I mean, I think, so part of the idea is that, if we had a multivariable model that had like race as a coefficient in it, that inclusion of that race coefficient would pick up effects associated with race and sort of like potentially attenuate the effect. It'd like soak up some of the variation caused by race. And so that is like one potential like downfall associated with that the multivariable model approach, whereas using race sort of as the outcome in this propensity like approach that I did allows us to kind of like try to at least analytically separate those concepts a little bit more. So other things that come along with being Black, like SES and income and other things that make like differences between whites and Blacks or something, that wouldn't necessarily be like wouldn't necessarily be included in the model in the same way that it would be for your standard multivariable model. And I've seen some papers that do some comparison on this, and like basically like they seem to show in this one example anyways that using the sort of the multivariable model resulted in an attenuation of the effect, an attenuation of the difference, right? Because some of that difference between races is being soaked up and stuff by the way the model is. And then using the propensity score version, then sort of as they frame it, at least like allows more of the disparity to sort of shine through. Does that help a little bit?
Yeah, no, it does. It does. I've heard the sort of the obscuring of the sort of race variable a lot, but I just couldn't make sense how propensity scoring could make the difference. But now I can understand. Thank you.
Yeah. I'm probably not explaining this very eloquently. But I'd be happy to share those papers with you. Marzia, if you want to send me a note.
Yeah, for sure. That'd be awesome. Thanks.
Yeah, of course.
Are there any other questions or comments?
You don't have to say it's like that you have a lot of really good one of the studies, but I guess I was
Can you speak up a little bit? We're having trouble hearing you.
Well, we lost her. Maybe I can ask one more then. Well, I'm very impressed with all these studies in North Carolina. It sounds like North Carolina is a very good place for doing research. I'm recently struck by this, these so-called transportability issues, right? And in your view, then, under what circumstances can we really try to compare results from different states?
Oh, that's what a good question. I think how do I think about this? I haven't done a lot of thinking around like my specific research and transportability. I think like the big argument that I have, or potentially like the rationale for using North Carolina as an example is, around this area of like the data that we need like to do these kinds of projects are state specific. So that's like just one thing, right? And then in terms of the transportability thing, I don't know. North Carolina has this eugenics program, right? Like, and I have a sense that is informative to like the way that different reproductive health policies have played out in that state. So I think getting to this idea of transportability, and particularly like around historical context, which is something I try to think about a lot, like I just don't even understand how we could possibly get there in like this example, yeah, but I would love to talk more about transportability with you because I have some other thoughts about it in a different context that's like around like racial identity and transportability and things. So anyways.
That you like maybe next time you're group meeting for research, I'll join and then we can talk. Yeah.
That sounds really great.
Okay.
I love that. Okay, and so there's a question in the chat. My question was about where you got your data or the different studies from. I'm struck especially by the second and the level of detail about the sterilization data for so long ago. Yeah. So those data, the eugenics board that I mentioned, they published or required by the governor of North Carolina to publish reports on like how well the program was going. And they published those every other year for the entirety of the program. So the data that I have and a lot of that I used was just abstracted from those reports. They did a lot of record keeping, you know, in this year, we did this many sterilizations in this county. And, you know, so I was able to grab a lot of that data and just abstract it from those reports. They also provided just such a nice wealth of information about like, here's what we did with our money. You know, the state like didn't really fund this eugenics program. They funded staff members to do it, but that's it. It was up to like local counties to actually fund the sterilizations and local doctors to do that like groundwork. But that kind of kept the program, at least in terms of reporting, pretty clear and cut and dried, which helped me. So that was like, to answer your question, that's like where those sterilization records come from. There's of course limitations to what those data look like, and there, you know, I could only find those reports for like a certain chunk of years and can't find them elsewhere, despite going to the state library and stuff. So yeah. And then the last, you had a question too about the level of detail in the last study about clinical considerations and different types of birth risk. So that is actually standard, I guess at this point, standard reporting in birth certificate data, or the Natality Files as they're called. So, and starting in, you know, maybe 2016, like all the states are, I think, more or less on the same page about the type of data that they're reporting and the types of variables that they're reporting in those birth certificates. So it's just handy that they all existed and I was able to use those variables. Of course, there's so much more that we would want to know about these births, but at least in terms of this like sort of first pass at like what could be some of these reasons for the variation between natives and whites in cesarean section, those data are helpful. Yeah. Thanks for the question.